Hi, my name is Simon Roux, and I'll be doing the first part of Ketamine in District Hospital, a talk for district anesthesia education. Dave Bishop will be doing the second part of this talk, and the idea behind these talks are to help medical officers and the occasional anaesthetist in district hospitals do some anesthesia a little bit better. And we hope you find this helpful, and we look forward to your participation and feedback. These are some talks that are already available. And today we'll be looking at a refresh on the drug. We'll be talking a little about a framework within which to use the drug, and then we'll move on to some practical advice. I'll be leading quite heavily on this SARSA guideline for safe use of procedural sedation and analgesia. There's some great stuff in there on ketamine, but also on a whole bunch of other drugs. And if you are interested in sedation, or if you want to read up a bit more about any of the anesthetic drugs, it's a really, really useful source. So let's talk a bit about your reality. We know that many of you are sitting in very rural settings with patients coming from far. When I worked in rural, the question was always, "Usukopi, where are you from? Where have you come from?" And by extension, where does that patient have to go back after their procedure? You're often in a setting where you don't have easy access to theatre for a GA, and the hospital's often busy. It's hard to get staff, equipment, and drugs to do the procedures that you want to do. Now, here are some of the procedures that you are probably doing at your hospitals: evacuation or retained process of conception, burns dressings, complicated by the fact that those are often for children, short and painful procedures in casualty, analgesia for patchy spinals, and sometimes even general anesthesia. To do those procedures well, we want to make sure our patients are comfortable and that their dignity is preserved. We do that by giving them the medication and giving them a service that it provides anxiolysis, analgesia, and sometimes even a general anesthesia. We won't go into procedural sedation in detail now, but it's good to be aware of this table. It's called the continuum of sedation, and realize that you can go from minimal sedation to moderate sedation to deep sedation to GA pretty quickly. And as you start affecting responsiveness and airway and spontaneous ventilation and cardiovascular function, your patients can land up in quite a bit of trouble. And how they respond to drugs differs from patient to patient, dose to dose, and it's really important to just be aware of this table. There are lots of different drugs you can use to make your patients comfortable, and we'll be looking a little bit at ketamine at the bottom of that table. So what does ketamine do? Well, it's a dissociative drug. So it dissociates the thalamoneuroccortical and limbic systems, so essentially the emotional brain. The CNS is, in effect, dissociated from the outside stimuli such as pain, sight, sound, all unpleasant experiences. And it causes a kind of a trance-like cataleptic state characterized by intense analgesia, amnesia, sedation, retention of protective reflexes mostly, and spontaneous breathing, as well as generally cardiovascular stability. The respiratory effects, well, pretty good. Does not cause respiratory depression when titrated and injected slowly, but it does cause increased saliva and tracheobronchial secretions. In terms of the neurological system, be aware that these patients can have hallucinations. Some midazolam might help to counter that, and they can have nystagmus, so you'll see their eyes moving back and forth. From a cardiovascular perspective, ketamine inhibits the catecholamine uptake, which exerts a sympathomimetic effect. So essentially, it's pretty cardiac stable if there are catecholamines around, or you might see a bit of tachycardia and increased blood pressure with these cases. So if you look at this, one of the beautiful things about ketamine is that you can give it in so many ways. You can give it orally, intravenously, intramuscularly, rectally, and even nasally. It's attractive and safe, mostly because of these many administration routes. It's quick onset of action. You can see with the IV, it's there 60 to 90 seconds. It gives intense analgesia, amnesia, and mostly keeps your protective reflexes and cardiovascular system intact. It's got a nice short duration when given in boluses, and it's got post-operative analgesia effects, which is great. And as you get more experience, it's also a nice drug to use with other drugs. In low dosages and low boluses, safety profile of this drug is really, really good. But beware, there are ketamine crocodiles. It is not the drug that'll without any issues. So just be aware that a rapid intravenous administration may lead to intense respiratory depressions. We mentioned secretions, and just to kind of pause on the depletion of catecholamines. If you have a patient that is shocked, that has been in a car crash and taken ages to get to you, if you give them ketamine, it won't be as stable as you might expect it to be for a general anesthetic. Just be aware of that. All right, moving on to a framework or a mantra within which to use ketamine. Well, we think it's just so important that you prepare well, and this is something, this mantra, this framework, you'll see coming up more and more and over in some of the talks that Dave does. And idea is that you need to start building a system. So the very first thing is to prepare well. Prepare your theatre, prepare your patients, prepare your staff, your team in theatre. Okay. So what are the kind of things you can do there? Something like this, a simple checklist. These are available in the SASA guidelines. Have a look at this. Ask questions. Be systematic about it. Prepare your theatre or your sedation space. Have as many of these things as you can, but at the very least have a AMI bag, oxygen source, and suction. Before you give anything, just pause. Check your dosage. Check your is this patient overweight? Are you feeling isolated? Do you have help if things go south? Is this patient intoxicated or elderly? Just pause before you give anything. Do the basics right, and that might very well be just doing the monitoring. Okay, so I like to monitor. I have a low threshold to monitor with SATs, BP, and ECG wherever I can, and that might not be possible for you. But when you are using two drugs that affect breathing, like benzos, ketamine, opioids, or when you're doing deep sedation, meaning you're affecting the cardiovascular, the respiratory, or the neuro system, do it. Another basic you can always do right: titrate. Titration eliminates guesswork. So rather titrate, give small dosages, be patient before you get to giving more drugs. And again, just be aware of the different vial strengths. Expect common complications, and this is part of preparing your team. Think about the apneas, think about those secretions, and think about the fact that ketamine, given lots of it, can accumulate, and that can be a problem for you in your post-op time. And that brings us to the last one, and that is to value the recovery period. Think of having something like this, just a checklist, something that a recovery nurse or yourself can go through. Have a discharge criteria, especially if it's patients that are going home, that have to travel far, or can't get back to hospital easily. Make sure these patients are awake enough before they go home. And these things are available at the back of the sedation guideline. All right, then lastly, the principles of safe ketamine use. Well, select your patients appropriately. Take time to evaluate them. Make sure you're not doing them a disservice by giving them ketamine. It's got a great drug, but there are a few side effects. And if you become callous with it and you're not patient, you can run into trouble. Be careful of patients that are not ASA 1 and 2. Be careful of the patients that are obese, that are intoxicated, the elderly. Be careful with those patients, specifically in an out-of-theatre setting. Know the drug, try and get accustomed to using it and giving it orally, IV, IM. Just get to know the drug. You'll realize quickly that patients respond very differently to it. And the more comfortable you are in giving ketamine to patients, the better your long-term service will be. Remember to give as little as you need to make the patient comfortable. So titration eliminates guesswork, right? So just give small dosages. Train your team around you. Help them to identify when patients drift into deeper levels with ketamine. Help them, cascade your knowledge, what you're learning, to junior doctors as well. And it's really important that when you are using ketamine, you are able to manage and rescue a patient and recover a patient that goes into a deeper level than what they need to be, and if the airway, for example, gets compromised, just to be aware of those things. Thank you very much. I'm now going to ask Dave Bishop to do the next section for us. Please let us know if you've got any questions.